Good afternoon. My name is Michelle Lane. I am the Senior Director for Community Health and Wellness at North Kansas City Hospital Meritas Health. I'm so happy that you could join us today for an informative session on shoulder health and injury prevention with Julie Harrison. She is an occupational therapist here with us and also a certified hand therapist as well. Julie has a deep understanding of the shoulder anatomy, its functions, and the specialization that it takes to enhance mobility, prevent injury, and promote long-term health. In this session today, she'll provide us some really practical insights into how the shoulder works, some common risk factors for injury, and some effective strategies to protect this extremely vital joint. I've had a shoulder injury myself and was luckily enough able to heal with occupational therapy and did not need surgery. So whether you're looking to prevent injury in your daily activities or during your workouts, this session will equip you with tools and tips to keep your shoulders strong, flexible, and injury-free. So please help me in welcoming Miss Julie Harrison.
My name is Julie Harrison, and I'm an occupational therapist and a certified hand therapist here at Kansas City Hospital. I've worked here since 1998. I went to Rutgers University. I graduated from there in 1996, so I've been doing this for about 28 years. I'm working currently as a lead therapist up at our Creekwood Clinic, which is one of the satellite clinics through North Kansas City Hospital. We do have 3 locations now for patients to receive their physical therapy, occupational therapy, and speech therapy services. Just to give you guys a little heads up on the difference between physical therapist and occupational therapist, to put it really simply in the outpatient world, occupational therapist, we treat issues from the shoulder blade to the hand. Physical therapists treat issues of the neck, back, legs. And we actually share the shoulder, but at our clinic, most people with shoulder injuries come to see occupational therapists. And also, if you've not heard of a certified hand therapist, I am also one of those. Certified hand therapists are folks that have been out of school for at least 5 years and passed a really, really hard exam, and that certifies them to treat from the shoulder blade to the hand. And there are about 7,000 CHTs in the US, and currently at North Kansas City Hospital, there are 3 of us. So to get on to talking about the shoulders. So shoulder problems are incredibly common. They're about 1/3 of the caseload that I have on any given day. And today I would like to talk to you about 2 of the most common issues that I treat at the shoulder, which is rotator cuff issues and frozen shoulder. So we like to start with a little talk about anatomy first. So moving right along here, just to show you guys the shoulder joint. It is the most mobile joint in your body. Your shoulder actually moves in 8 different directions, which gives you fantastic mobility, but the cost is that you have a lack of stability, and it's very easy to injure. The shoulder is a ball and socket joint. It's made up of this bone here called your humerus, which fits into this shallow socket called the glenoid. And the glenoid is made up from the shoulder blade bone. So this is what you think of as your shoulder blade here on the back of the shoulder. The fancy term is your scapula. And what also joins this to your body is an attachment through your collarbone, which actually attaches your whole shoulder to your sternum and your torso. So, and the last joint to talk about here is the scapulothoracic joint. That is where your scapula or shoulder blade sits against your rib cage. And here on the X-ray version, you can just see how much larger the ball is than the socket. It's about twice the size of the socket, and it's held together with a joint capsule and a lot of ligaments. And those are actually the structures that get into trouble when you have a frozen shoulder, which we'll be talking about here in just a second. I'd like to talk just a little bit about the shoulder blade itself. The shoulder blade is really fascinating. It is what the shoulder socket is made up of, and it attaches to your body via ligaments. It actually also rests against the rib cage, but there's no bony attachments of it to your rib cage. The position of your shoulder blade is dependent on the 17 muscles that attach to it. And so your posture very much affects the position of your shoulder blade. This is the base from which your arm moves, so it is very important. And if it isn't stable and moves too much or too little, shoulder blade dysfunction can definitely be a cause of shoulder pain. So this slide is just showing you how your shoulder blade is supposed to move up, down, in towards the spine, around the rib cage, and it also rotates upward at the bottom edge here. That's going to be a concept that we're going to talk about in quite a bit of detail, and it can also have that bottom edge rotate in towards your spine. Moving right along, this slide shows you some issues that can happen with the shoulder blades. You can see how the shoulder blades aren't always a matching set. So you can see how if in this first slide, the bottom edge is sticking out. On this one, that whole medial border is lifted up. And on this image C, the shoulder blades are not symmetrical at all. One is much higher on the back and one is much lower. And both of them have edges that are tipped away from the rib cage. So it might be interesting for you to see your own shoulder blades. If you ever take a look in a mirror, you can rig up some mirrors in your home to see what your shoulder blades are looking like from the back. And if you raise your arms up, especially if you have like 3-4 pound weights in your hands, and then slowly lower them down, it is really interesting to see if your shoulder blades move symmetrically or asymmetrically or lift off the rib cage. Next up, just one more thing about the rib cage, about the shoulder blade, is this is just showing the ideal positioning of the shoulder. So what we're looking for ideally is that the shoulder blades are symmetrical. I mean, of course, it'd be nice if we all had a body like this, but what we're really looking for is that the shoulder blades are symmetrical on your rib cage as far as the height of them, and that they're placed against the rib cage and are slightly upwardly rotated, like this fellow here, where the bottom edge is pointing away from the spine in relation to that top edge should be closer to the spine, as opposed to this individual where you can see it is a downwardly rotated angle. And if you have a downwardly rotating angle, that can just put you at more of a risk of impinging your rotator cuff and having that be a cause of your shoulder pain. Next up, I'd like to add on some of the muscles. So this is, there's a ton of muscles to the shoulder, but this is just adding that deepest layer, the rotator cuff. So these are your rotator cuff muscles. There are 4 of them: your supraspinatus, your infraspinatus, which is shown here, the teres minor, and then also the subscapularis, which is shown here. And these are muscles that completely enclose your shoulder blade. They start at the edge of your shoulder blade and they course across the shoulder blade and they attach here on the side of the arm bone. And their job is to work together to hold your humerus or ball down in the socket when you raise your arm. They also function to help raise your arm out to the side, put your hand behind your head, and reach your arm behind your back. So when people have rotator cuff issues, what we're looking at is an issue of the tendon here at the end. My next slide shows that in a little better detail. So you can see that it's a muscle. So the red is the muscle and the white is the tendon. And it starts as muscle, courses across that shoulder blade, turns to tendon, and the job of the tendon is to attach the muscle to the bone. What you see here is the large subscapularis muscle. It's what's in charge of bringing your arm behind your back. And up top here is the supraspinatus. This is the tendon that's most often injured in a rotator cuff injury. And you can see why, because it lives in a really vulnerable spot between the ball and the top of the socket. And we're going to talk about that in much greater detail, but you can see here where if this space is smaller, especially with bad posture, if that scapula is tilted and narrows this space, that can be big trouble for this rotator cuff tendon. One more thing that's shown on this slide is the long head of the bicep tendon. Oops, sorry. The long head of the bicep, it actually, the bicep is this muscle here that bends your elbow, but it actually has two heads. One attaches here, again, to this bone called coracoid, and one attaches here into the shoulder joint itself. And I'm just pointing it out because it can be a big driver of pain as well, especially along the front of the arm and the front of the shoulder. Okay, moving along. We've been talking a lot about the scapula and the role that it plays in shoulder pain. So just to talk to you a little bit about what is supposed to happen, when you raise your arm up to the side, your shoulder blade really isn't supposed to move much in this first 90 degrees of motion. But then when you raise above shoulder height, it's supposed to upwardly rotate like this exhibit right here, where that lower edge is coming out away from the spine as you raise your arm. And this upward rotation and the ability to raise the arm happens whenever there's groups of muscles that work together. There's two different ones at the shoulder that they're called force couples, and we need those muscles to work together in order for your arm to move without pain and normally. And if certain muscles are weak or tight, or if those tendons are torn, that will screw up the way those muscles work together and can be a cause of your shoulder pain. So shoulder pain is typically due to issues of three different structures. Shoulder pain can come from joint or capsule issues, which results in conditions like arthritis, frozen shoulder, labral tears, or instability. It can come from muscle or tendon problems. That's really the most common, and that's usually from issues at your rotator cuff or that bicep tendon. And that results in pain, usually here to the side of the arm, the front of the arm, or even down past the elbow. And the third structure that can be the reason for shoulder pain and arm pain is a compression of the nerves as they exit your neck at the cervical spine, or also here in this area between the neck and the shoulder. And compression of the nerves there is called thoracic outlet syndrome, and that can result in pain, heaviness, and issues that extended down the entire arm. So let's talk about the joint problems first. So this is examples of a frozen shoulder. So just to talk to you a little bit about what a frozen shoulder is. Frozen shoulder is a condition that's characterized by often really severe shoulder pain and restricted active and passive range of motion, meaning both the way you can move it and the way someone else could stretch it. X-rays are going to be normal in something like this because there's nothing actually wrong with the bone. What is the problem is the capsule. So here it shows a normal joint capsule. And again, just to review, the joint capsule's job is to hold that big ball in that small socket. So a healthy normal joint capsule looks like this. A frozen shoulder joint capsule looks more like this, or this guy on the right, where you have an inflammation and a thickening of that shoulder capsule. And depending on what part of that capsule is tight, you'll have issues with how you can move your shoulder. So for example, if the back side is tight, you'll really have a hard time with reaching your arm behind your back. If the front side is the more of the issue, you'll have more trouble with raising your arm behind your head. And if the under at the inferior or the lower section is tight, that will result in trouble raising the arm out to the side. Though people can have problems also with raising the arm moving the arm in any direction. So as far as some statistics about frozen shoulder, it isn't all that common. It's much less common than rotator cuff issues, but it does happen to about 3 to 5% of the population. It's often happens whenever you're around middle age. It's seen in 35 to 60-year-olds, more common in females than males. And the cause isn't known, but it's thought to be due to changing hormone levels around menopause for women. It's also seen more often in people with diabetes, thyroid disease, coronary artery disease, and Dupuytren's disease, which is a collagen disorder that results in the drawing down of a finger into the palm. This can happen really suddenly, or I mean, I've had lots of patients that just say they woke up and they were in terrible pain, or it more often happens more gradually, and it starts with pain. Often people don't want to move because they hurt, and then it progresses into that stiffness. So what are we going to do about it? Very often therapy is the first line of defense with a frozen shoulder. Sometimes a physician will also give a cortisone injection or some steroids to decrease that inflammation and help us regain that range of motion. But just to talk to you a little bit about what happens if you come to therapy, we'll gather your history, we'll find out more about your pain, if it's more present at rest, with activity, what makes it better, what makes it worse. We look at your posture, your range of motion, your strength. We perform special tests. We look for compensatory patterns, like if you have to do excessive movement from your shoulder blade to get your shoulder to move. We assess how your shoulder feels and compare it to how far you can move it versus how far we can move it, which tells us more about if this is a joint issue or a muscle issue. And there is a very distinct feel to a shoulder, a frozen shoulder. It doesn't feel like anything else whenever I move it in my hand. It's just got what we call a very firm or hard end feel, where it just is really stuck, and it's very, very difficult for us to move and for the patient to move. So what do we do to get it moving again? We will need to get in there and start mobilizing that joint. So these are some examples of how we will be doing some joint mobilizations to get more motion between that ball and socket and start to stretch that joint capsule back out so that it isn't locked down like a vise anymore. Because that joint capsule, if you remember that really red and inflamed joint capsule, it actually, in a normal one, especially the underneath, the inferior portion, it actually looks more like an accordion, where when your arm is down, the folds of the accordion are closed. But as you raise your arm, those folds should open and widen and allow you to move the arm. And with a frozen shoulder, it's just really locked down tight like a vise. So we get in there and start to mobilize that shoulder joint with what we call joint mobilizations. Here, he's pushing down on the shoulder joint. Here we're pulling out on the shoulder joint. Here we're moving that shoulder blade in all directions, just again to try to loosen that up. We would also get in and stretch the soft tissue, meaning the muscles and the tendons. That we do that with massage, either manually with our hand or with some tools. That will also help to decrease the pain. And depending on what part of your motion is tight, your therapist will give you stretching in the clinic, where we'll work on stretches together, where we assist you, and then also where you'll be giving yourself stretches to regain your mobility. And we will give you a home exercise program that you'll do. We can issue that on paper, or we also have digital copies where you can download an app and do your exercises along with an app on your phone or your computer. These are some examples of some more strenuous exercises. To tell the truth, these wouldn't be ones you would be starting with. These would be more ones that you would get more towards the end of your therapy, to when your range of motion isn't getting closer to normal. But frozen shoulders, they can take weeks to months to fully resolve, and it takes a lot of work to get those back to normal. So we usually see people twice a week in therapy, and you work with a daily home exercise program. If we are not able to get your range of motion back, the physicians do have some options that you can look at surgically, where they may do what's called a manipulation under anesthesia, where they would put you under anesthesia and then and basically crack it loose under anesthesia. If that is not an option, they can also surgically open the shoulder and then cut away some of that joint capsule that I showed you earlier. And by cutting away that inflamed tissue, that will free up the shoulder joint and allow the range of motion. So that is what I had to say about frozen shoulder. Next, I'd like to switch gears and talk about rotator cuff issues. So rotator cuff issues, they are probably the most common issue that I see. And in fact, over 2 million Americans suffer from a rotator cuff injury every year. They are the most common tendon injury in adults. I mean, you've probably heard, especially with football season, about other tears of tendons like an Achilles. So you can tear tendons anywhere in your body. And again, just to review, a tendon is the structure that connects a muscle to the bone. So every one of your muscles has a tendon, and every one of those can be susceptible to injury and tear. But the rotator cuff is number one. Here is an example of a rotator cuff tear. This is that supraspinatus, the one that I said is most commonly injured because of where it lives here between the ball and the socket. So this is an example of a very bad tear. This would be a full thickness tear. If you guys have ever had shoulder injuries, you may see on an MRI where they may talk about a partial thickness tear or a full thickness tear. And the difference there is just talking about the depth of this tear. So when you have full separation and you can see the bone underneath, that's a full thickness tear, where the pieces are completely separated. There can also be a partial thickness tear, and those are really common as well. And that's where you'll have some fraying of the top portion, or sometimes some fraying of the under portion, but some of this is still intact and some of it is torn. So that's the difference between full thickness and partial thickness. And then you may also see on an MRI report, they may talk about a small, medium, large, or massive tear. And that is indicating how long the length of the tear is. And my next slide will go into that into a little more detail. Keep in mind there are 4 tendons of that rotator cuff, and you can have tears of 1, 2, 3, or 4. I mean, you may have a tear of all of them. So the more massive the tear, of course, the more severe your issues are. This talks a little bit about the different grades of those full thickness tears. And again, we were just talking about how wide the tear is from the width perspective. And of course, you would like a smaller tear than a larger tear. If you have a massive tear, you won't have great range of motion. You'll probably be trying to lift your arm like this, and those therapy is limited in our ability to fix. But we'll go into that in a little more detail here as far as reasons for rotator cuff tears. There are lots of reasons why a rotator cuff can go south. Degenerative change as you age, repetitive microtrauma like from repetitive overhead lifting or overhead sports. You can tear your rotator cuff with a trauma like a fall on an stretched arm, or really excessive force that you weren't expecting, especially like trying to catch something heavy that is about to fall. Also, you can get a rotator cuff tear with shoulder dislocation. Posture and muscular control also play a very big part in contributing to rotator cuff issues, as well as the shape of your acromion, which is this bone right out here at the edge of your shoulder blade. Just to talk a smidge about prevalence of rotator cuff injuries, I know I've said that they're common, but just to give you a few more statistics, in adults over the age of 60, about 30% are known to have a rotator cuff tear. And in adults over the age of 80, 62% have rotator cuff tears. I myself have had rotator cuff issues after I was hit by a car as a pedestrian, actually several years ago. And I've been able to exercise my way out of the problem. So I never had an MRI to actually tell me how bad my rotator cuff issues were, but they can vary a lot as far as their severity. And I know this slide has a lot of medical terms, but I'll just briefly go through it. It's just mainly to let you know that your posture and the way your shoulder moves, as well as weakness and tightness of your muscles, can all contribute to the health of your shoulder and into the factors in how we treat you. I may just go to the next slide I think it's always easier to see what somebody's talking about instead of just reading a slide. So what we're looking at here is just a side view of the shoulder if you were looking this way. And this is just showing you again the arm bone coming up and the top of that shoulder blade bone, the acromion. And you can see how that rotator cuff lives right between the ball and the socket. And it covers from the front of the shoulder around to the back. And these muscles, they have to work together to keep that shoulder ball on the center of the socket. And if you can imagine if one of these was torn, that the ball would tend to ride a little higher in the socket if they aren't all stabilizing and working together. And that can lead to what we call impingement, where if the ball is riding too high in the socket, then you're going to get more pinching of these tendons where they live under that bone. Also, things that contribute to shoulder pain is your posture. So you can take a look at this gentleman, and I mean, I think his shoulder probably hurts before I even hear anymore whenever I see this kind of posture, because that rounded posture that you see there, that is going to make the muscles here on the back extra long and the muscles on the front extra short. And your rotator cuff is going to be on a stretch here before you even start to lift your arm. Also, if that shoulder blade is tilted around this way, that's really going to narrow that space that I keep talking about between the ball and socket and just really make you vulnerable to injuring your rotator cuff. If you can imagine trying to lift a weight or, lifting a dish overhead or lowering a crock pot from an overhead shelf, and your position is like this, you're just really setting yourself up for trouble on that shoulder. This slide shows, again, what we're calling that impingement syndrome. And impingement syndrome is meaning that as you raise your arm out to the side, like I'm showing right here, that supraspinatus tendon is going to get pinched right here between that ball and socket. And there's also a little, like a bubble looking thing right here. That's your bursa. It's a fluid-filled sac that helps the tissues glide and move, but that can also get pinched and inflamed, and that's what bursitis is. And that will further narrow that space if this is all inflamed and swollen and make your arm hurt. Oh, and one last thing I was just going to show you here. This is called the painful arc, where that is the area where the pinching is the worst. When you're down low, doesn't really, that ball and socket, they aren't in a position where that rotator cuff will be pinched nearly as much as when you're in this mid-range. And then once you raise up higher, the ball has passed that pinch point, and it really doesn't hurt too bad there either. So if you've ever had pain here in that mid-range, that's the reason why. Okay, moving right along. A couple more notes about your anatomy. So the acromion, just to go back a smidge, that is this bone here on the top. Well, just another little aside is that we can actually be born with different types of acromions. So some of us are born with nice flat ones, and some of us have this kind that are more curved or hooked. And those types of acromions will further crowd the space and can also set you up for issues with your rotator cuff. And back when I started practice in the early 2000s, you saw something called a subacromial decompression, and that is where the doctor will just shave off the bottom of that hook to give you more room. And that was done really, really commonly when I started practicing, but you don't see it quite so much anymore. There was a recent study in the British Journal of Medicine back in 2021, and it shows that 5 years post-op, that subacromial decompression really did not provide any more benefit over therapy exercises or just a placebo surgery where they just cut you and they didn't actually do anything. So that was further research that just showed that perhaps the role of the acromion isn't quite as important as they once thought. But lots of people have had that procedure, so I just thought I'd throw that in if that is a term you've heard of or a surgery that you've had. Okay, just touching just a little bit more on some other factors that contribute to rotator cuff related pain. So yes, I know I've given you lots of reasons to worry about your rotator cuff, but here are a few more things that can influence it. It's more common in folks over the age of 50, folks that have a lot of overuse of that arm with repetitive activities or overhead sports. Poor blood supply to that tendon also can contribute, as well as diabetes, smoking, and obesity. So what does a rotator cuff problem look like? If you had a trauma like a fallen out stretched arm, you're going to have some severe pain. Also, even without a trauma, rotator cuff issues often present with pain at night. Pain, especially sleeping on that side, is incredibly common. Pain that is worst when you raise your arm out to the side, especially in that mid-range. We often will see that passive range, meaning how far we can move it, is better than how much a patient can move it themselves. But stiffness may also be present, as well as weakness. We find weakness and pain in that involved muscle, and it often presents with a dull aching pain, usually often here on the side of the arm, but sometimes also on the front. Oh, and also pain that goes right here to where your deltoid muscle inserts. That is really classic for rotator cuff issues. So if you come to therapy or go see the doctor, there are some tests that they will do to decide if the rotator cuff is the problem. And here are just some pictures that show you those different tests that we would perform. And that helps us really hone in on what part of the rotator cuff we think is the issue. And then what will your therapist do? So when you come to see us, we'll be assessing your range of motion, your strength, all of the things that I showed you in the beginning that we would also be looking at if someone had a frozen shoulder, but they'll also be assessing your motor control using this little system that we call the shoulder symptom modification procedure. So if we identify that when you raise your arm to the front, you have pain, we will do some of these little maneuvers that are listed here where we'll help guide that shoulder blade up and away. We may also try having you stand up straighter, or we may try pressing backward on your ball of the shoulder joint, and we'll see if that decreases the pain, and that helps guide us on what exercises would be most beneficial to you. So here's a slide of a therapist guiding that shoulder blade up as you do overhead reach. And we may tape you to facilitate that motion, but we'll definitely be giving you exercises and stretching to help facilitate that motion. Again, we may find that standing up straight and assuming better posture helps to decrease that motion. And if that is the case, then we may give you exercises like you see here, where you may be leaning backwards in a lower chair to increase the stretch to your thoracic spine, or leaning back over a bolster, or just working on just actively reaching your arm while sitting up with better posture. If that upward rotation of the scapula that I showed you a few slides ago, if that is a big help to people's shoulder pain, which it often is, then we'll do exercises that strengthen a muscle called your serratus anterior. And these are just a few examples of that first one. The person is raising that weight up towards the ceiling, and that will fire the serratus. Also sliding up and down the wall with some resistance against the arms is another way to really activate that muscle. So just to talk a little bit about treatment, when you come to therapy, your treatment is tailored to what you need. So if your pain is severe, we would start with things that make you feel better, like taping your shoulder, modalities like our cold laser or electrical stimulation, low-level mobilization to that joint. We also do a lot of patient education on how to move, how to modify your activities to avoid the pain, how to sleep in better positions, and how to perform better reaching patterns that are meant to focus on what you need and how you move. We also just start with really gentle exercises that don't increase your pain, because the whole point is to get your pain down. Here's some examples of things that we would do in the early phase whenever that shoulder joint is really irritable. These are two different taping methods using different types of tape. This is called kinesiology tape. There's several brands out there on the market, and we carry a few different brands here at our clinics. This is just an example of what's called an epidermis dermis fascial taping, where we apply the tape with a very light stretch, about 10 to 20%. That stays on for about 3 or 4 days, and we can replace that whenever you come back in. This is much stronger tape that we can also use that is more for a postural correction to remind you to sit up taller. And then here in the middle is just an example again of those joint mobilizations that we can perform to help decrease your pain. A few more examples of what kinds of things we do whenever pain is high. This picture on the left is of a person receiving dry needling. There are physicians in my clinic that I can speak to. We have 3 physical therapists in our clinic that are trained in dry needling. All of our 3 clinics have this service available if we find that it is appropriate for you. And there's also other modalities we use, like this is a cold laser. That is something that's used to decrease pain and inflammation. And then there's exercises that we do when the pain is high. Often we start with something really gentle, like an isometric like this, where you're just providing a little bit of resistance to that shoulder, but well below the level of the pain. And then as you progress, we advance to exercises that are more challenging for you, where maybe you're washing the wall to, again, get that shoulder blade to move better and to stretch out that shoulder joint. This is an example of an exercise we call the lawnmower, where you're working on those shoulder blade muscles, either with a weight or this is a resistance tube. We also have resistance bands that we use. And this would be an example of, again, working on shoulder blade stability, strengthening. These are strengthening the muscles there between your shoulder blades. So these are all examples of things that we'll be doing later in your treatment once your pain is under control and we're just trying to get that joint moving normally and that strength and balance back in your shoulder so that you can regain your full range of motion and strength and get back to normal function. If your shoulder is not improving with therapy, or if you have such a tear that therapy was never indicated in the first place, you may be looking at rotator cuff repair. So I just thought I would throw in just a little slide that just shows a little illustration of what a rotator cuff repair would look like. The physician would go in and pull that tendon back out to length here, and then put suture material in through that tear and then anchor that down to the bone. So the sutures actually go through the bone and adhere that tendon back down into the bone. And if you did end up with a rotator cuff repair, just to prepare you, that is a big surgery and one you don't want to take lightly, because it's about a 3 to 6 month recovery on a rotator cuff repair. You typically have to wear an immobilizer, sometimes with your arm out to the side a wee bit to take the pressure off of that repair with a wedge. So if you've ever seen somebody in an immobilizer, it's a sling with a kind of a foam block here. You wear that for about 4 to 6 weeks. And during that time, you would be coming to therapy just for passive stretching and movement to your elbow, wrist, and hand and shoulder blades, but no active movement to that shoulder, usually for about 4 to 6 weeks. And then at the 6-week mark, we're allowed to start moving it actively. And then a few weeks later, depending on your surgeon's protocol, we would start some strengthening. So those timeframes are all general. It depends on how quickly your physician wants to progress. We're provided with protocols for each patient, telling us and guiding us with how quickly the surgeon wants you to proceed. And that all depends too on how severe the tear was and how well they were able to repair it. So wrapping it up in summary, you just want to remember that motion is lotion and you want to keep your shoulders moving. Just the importance of really maintaining that good posture, especially as we age. If you are having shoulder pain, you want to unless it's a frozen shoulder. If it's a frozen shoulder, you want to keep moving. But if it's a rotator cuff issue, you would want to avoid that motion that's painful. But see if you can improve your pain just by changing that posture. And if you're able to move easier and with less pain. You want to keep that rotator cuff lean, mean, and strong as you age, and be sure to include it in your strengthening and fitness routine. You just saw from all of those slides, those rotator cuffs, they are really susceptible to injury as we age. So you want to take really good care of them. And also just the importance of maintaining your flexibility with the stretching program. Yoga is a great way to maintain that shoulder flexibility. And finally, if you're having shoulder problems, you can always come see us. So both occupational therapy and physical therapy can treat shoulder problems. Physical therapy is now a direct access. We have direct access now in the state of Missouri, as well as Kansas. So you can actually see PT now without a physician referral, that you can just call and make an appointment. For occupational therapy like me, we do still need a physician referral. And this is our contact information. And just finally, I was just going to give credit. I did follow a class that I took at the American Society of Hand Therapists Conference about a month ago, 2 months ago. And a lot of this information was taken from that presentation. So I can open it up to questions at this point. Let's see here. Michelle, if you want to guide me on that, that would be great.
Absolutely. Chad, I see that you have your hand up. If you could use the question and answer feature in the Zoom, it's on the bottom where you found your hand raised. You can enter any questions there and we'll get those answered for you. Julie, that was great. I thought that was so interesting. You know, the big takeaway for me is how poor my posture is and how much that has led to so many of my own problems. But, you know, when I wake up in the morning, I do some simple exercises that were taught to me by my therapist, really just to keep that motion going and keeping, you know, the lotion within that joint. And it has really helped me. I did not need surgery with my tears. I did go through a whole full round of therapy with Lawrence at the clinic, and he helped me recover. I still do my exercises because I'm just so afraid. I don't want to have surgery for sure. But it looks like Kenna had a question that said, can you provide the contact number again to call for the appointment? And I think that was your last slide there, or if you just want to share it.
Yes, yes. So I'll see if I can pull it back up, but I can definitely tell you it is 816-691-1795 is that contact information.
All right. Well, thank you so much for joining us today, Julie.
Right.
That was great.
Okay, thank you.
Bye.